Hello, welcome and thanks for joining Senzyme's webinar on monitoring respiratory volume in non-intubated patients. Why and how? My name is Kai Krüger. I'm the sales director for the Experian products, and it's my pleasure to introduce our two speakers, Professor Luciano Gattinoni and Professor Davide Chuimello, who are going to talk about why tidal volume and minute ventilation must be measured in spontaneously breathing and non-intubated patients. A few housekeeping rules. All participants will be on mute during the webinar, and after the two presentations we will open the chat forum to allow for questions to be posted and then answered by our speakers. Now it's my time to hand over to our first speaker, Professor Gattinoni. Please enjoy the webinar.
Good morning to everybody, and good afternoon. So this is a very interesting topic. Why tidal volume hyperventilation must be very spontaneous breathing, non-intubated patient. Now, my dear colleagues, tell me, what do you monitor when you have a patient in spontaneous breathing? During mechanical ventilation and normal ventilation, we monitor almost everything. We know the pressures, we know the volume, we know the name of the patients, we have the pulse oximeter, we have the PCO2, we have the entitled CO2. In spontaneous breathing, we just have sometimes an idea of tidal volume, but sometimes, and just when we have a control, as an example, an invasive ventilation, which is questionable, and almost nothing else. Pulse oximeter and looking. So you have this big jump between what we do with the mechanical ventilation and what we have with spontaneous breathing. Now, let's start to have an idea of my idea about the spontaneous breathing and how to monitor the situation. Now, this is an old slide from Professor Weibel. Weibel was, most of you probably do not know who Weibel was. Weibel was a giant in our specialty because was practically the only one who put together anatomy and physiology in a beautiful way. And this is the part of Weibel work in which he just was saying how all our lung, the skeleton of our lung is interconnected. That means we have, starting from outside of the lung here, this is the visceral pleura, we have the septa, and everything is connected. So we have an unicum skeleton. When we distend the lung, all the extracellular matrix distend. And let's conceive the extracellular matrix as something like that. We have some elastic part, and we have, which is the elastic part is here, is a sort of spring with distend, and inside we have the collagen fibers. The collagen fiber acts as a stop length. That means when you have distended all the fiber, you reach the total lung capacity, which is the physical limit of the lung. So I think when you consider the ventilation, mechanical ventilation or spontaneous ventilation, you have to consider which are the limits of our battlefield. And the limits of our battlefield are dictated by the anatomy. And inside of the anatomy of the intrinsic characteristic, the elastic characteristics, and the collagen characteristics. Now, when we have this kind of structure and we apply a force, when you apply a force to this structure, we have modification of the shape. This modification is called strain. That means how much is the change in length compared to the resting length. And the stress is the internal force, which develop inside when we have, when we have the force inside, when we have which react to the external force. That means apply the force, all the molecules inside react to resist this force changes. To resist this force, and this is the stress, and together we have this strain, this elongation. Stress and strain are applied at each breath, and they are applied at some frequency. Okay? Now, if I have to look at all the system, this is an old graph which is derived from the Handbook of Physiology. You can imagine that I apply the force, and the force is the transpulmonary pressure. The stress is equal to the transpulmonary pressure applied with the opposite sign and is associated with strain. We have a resting situation, then we have some strain up to the biotrauma, and at the end of the story, we have the stress at the rupture. Now, usually in men, when you have a 12 centimeter of water of transpulmonary pressure applied, we have about doubling, we are doubling the FRC. And of course, we are different in animals. So be careful when you read literature and you say, and you read, as an example, we applied protective lung ventilation to mouse, and you have 6 milliliters per kilo of mouse. It's completely different from man. It's completely different from pig. It's completely different from rat. Because the human and pig and rat characteristics of the lung are different. They reach their own total lung capacity a different way. Why I insist on total lung capacity? Because the tidal volume, which is a fundamental variables when you use mechanical or spontaneous breathing ventilation, is a fundamental role in this complex. As an example, let's see, this is my lung volume, and this is the resting volume, functional residual capacity. Let's see, I applied this tidal volume. This tidal volume divided FRC is equal to the strain, okay? And there is no problem. I don't have any PEEP, and everything is okay. Now, let's see, I have a PEEP volume, and the PEEP volume increases the FRC up to here. Now, when I start with the tidal volume, I go close to here. Now, when we have a patient, remind you, when we start to ventilate a patient, spontaneous breathing or mechanically ventilated doesn't make a greater difference. You start with the lung volume, which is we call a baby lung. If you have an idea of what is the total lung capacity, you have to multiply your baby lung between 2 and 3 times. Let's say I have 1 liter. My total lung capacity is about 3 liters. If my PEEP volume is 1 liter and my tidal volume is 500, I'm very close to here. And of course, when I have a further increase of PEEP at each tidal volume, my risk is to overcome the physical limit of the lung. Now, you are hearing me at this moment. Try to take the deepest breath you can. You are at total lung capacity. Now, try to overimpose over there your tidal volume. Try to do 15 times per minute, 20 times per minute for 1 hour. You are dead. Because the physical limits are extremely important and the variation of volume are fundamental. The tidal volume, which usually is spontaneous breathing, we do not measure. And when the strain is about 1.5, that means the tidal volume plus the volume of PEEP is 1.5, the FRC volume, we have a great damages in to the lung. And this, of course, is one of the few studies, one of the 3 studies, in which we were able, in 40 years, to show that something positive in mechanical ventilation. We have the low tidal volume, low, 6 milliliters per kilo, which is practically a normal tidal volume. In a normal man, we do not breathe more than 6-7 milliliters per kilo. Together with prone position are within the few things that tell us some advantage in mechanical ventilation. Remind both prone position and tidal volume relates to have a decent strain into the lung. Both are based on decreasing the excessive stress strain. Okay? Now, what's a spontaneous breathing? Where is the real difference between spontaneous breathing and mechanical ventilation? First, in spontaneous breathing, we have unbelievable lack of monitoring. We do not measure the tidal volume. We do not measure, we do not record, unless you go there, but this happens very rarely. Respiratory rate, not having tidal volume respiratory rate, you don't have minute ventilation, and you don't have no information about entitled CO2, the CO2. We have just a pulse oximeter and look at the patients. Now, this his experience is one the possibility to tell you minute ventilation, that means respiratory rate, and tidal volume. You know, personally, when somebody called me, when I have a patient, and the patient is a very terrible situation, I don't ask as a first how much is the FiO2 and how much is the PO2. Remember, the status of the lung is far more defined by the CO2 clearance. So I ask how much is the PCO2 and this PCO2 at which minute ventilation is measured. Because if I have a 45 of PCO2, my minute ventilation is 12 liters per minute, the patient is a disaster. If I have 45 and my minute ventilation is a 7, is a completely another world. So the information about the total ventilation that I have to pay to clear the PCO2 is essential because the PCO2 clear reflects the anatomical status of the lung structure far more than oxygen. And you know, the same patient on Monday, maybe the PO2 stay more or less the same. On Monday, you need 9 liters to have a 45. On Tuesday, you have 9.5. On Wednesday, 10 liters to reach the same PCO2. Or the PCO2 goes up very slowly. These tell you that the lung structure is changing in this patient. So the importance of knowing or measuring what you are observing. And why ventilate? We ventilate to remove CO2. I can keep one patient, we kept patients for months without any ventilation, removing the CO2 with extracorporeal means, and just oxygenating the patient, giving the amount of oxygen equal to the oxygen consumed. To oxygenate, you don't need any ventilation. You need to provide oxygen 200, 300 milliliters per minute, that's it. But to remove the CO2 that start with a lower concentration, you need an important amount of ventilation. And with the mechanical ventilation, we do not replace the alveolar endothelial function, the capillary alveolar function. We replace just the respiratory muscles. We provide energy sufficient to move to the system. This energy may be too low or may be too high. And we concentrate overall on the too high ventilation, of the inappropriate ventilation, which may be equally, if not more, dangerous than the lower ventilation. Now, just consider this slide, which is, I think, is quite important. Let's say I have a patient in mechanical ventilation. What is from the total energy to move the respiratory system in the patient comes from where? Comes from the ventilator. Let's see, the patient is paralyzed, big sedation, unconscious, etc. So all the energy comes from the electrical energy that I pay for that. Okay. When I have spontaneous breathing, I generate negative pressure in my pleural space, and my energy, total energy, comes from the muscles, and which is the P muscle. What moves the lung? In the lung, in a positive pressure, is the transpulmonary pressure, the difference between airway and the pleural pressure. Let's see, 20 and 10, 20 on airway, 10 in the pleural pressure, transpulmonary pressure is 10. In spontaneous breathing, usually my airway pressure is 0. So what moves the lung is still the transpulmonary pressure, but because I make more and more negative the pleural pressure. And what makes negative the pleural pressure is the word pressures, which is usually ignored, but is the equivalent in terms of physiological meaning of the pleural pressure during the spontaneous breathing. So, in a sense, what changed in terms of providing energy is just ventilator and muscles. But all the rest, in terms of mechanics, is not so different. I don't care what is the motor. What is if the transpulmonary pressure is the same, the movement of the lung is exactly the same. But there is one great difference. What is this great difference? You can see here is the pressure inside of the thorax, the intrathoracic pressure. When I have positive, my hemodynamic has a problem. When I have negative, I suck blood in the central part. So with the negative pressure, let's see, for the same transpulmonary pressure, I have also sucking blood. And sucking blood means more fluids and means also usually more edema. For the same very high tidal volume or respiration, the negative pressure may be even more dangerous in terms of generating edema than the positive pressure ventilation. For the same changes on lung structure, my dear colleagues, what really creates VILI is the interaction between lung and hemodynamics. If my fluids are 0, edema is 0. So to create edema, to create all the problem we have during the ventilator-induced lung injury, we need the interaction with the hemodynamics. And this is the big difference between spontaneous and mechanical breathing. So transpulmonary pressure is too low. I don't want to waste time. But of course, is the PCO2, atelectacy, hypoxemia worsening, hypertension, failure of the ventricular, right ventricular. But if transpulmonary pressure too high, I have other problem, which has the injury extracellular matrix, overdistension, etc. Now, this is an older study which was done by mentor, was Dr. Korobov. Korobov was a genius. Was a man who invented the spiral coil membrane lung, which were used for 30 years at least. And they were injecting here with Mascheroni, Fumagalli, and so on, were injecting in the 88s. Nobody spoke about this kind of thing at that time. Was injecting in the cisterna magna of the sheep some acid. And what they found? A tremendous ventilation because the spontaneous breathing sheep wanted to breathe because they have acidotic acidotic fluids in the brain. So the respiratory drive was very high. The ventilation was extremely high, milliliters per kilo. You know, here is here the ventilation. You can see. And these are the control in mechanical ventilation. In 24 hours, the spontaneous breathing sheep had a tremendous, what they call ARDS. And I think this was not the first demonstration of the danger of spontaneous breathing, but was the first demonstration organized in that way. And I think this paper was ignored for decades because they say, well, spontaneous breathing is the best because spontaneous is something spontaneous, sounds good. But spontaneous breathing may be deleterious because depends how much energy you put in the motor. I don't care if the energy is due from the ventilator or from the muscles. The effects are stress, increased stress and strain. Let's see. I have stuck the diapo. Okay. And I think a great example of this we had in the COVID. You know, to the first COVID wave, no ventilator, a lot of patients coming, hypoxia, the people were jumping on this patient, and the patient was breathing as a hell, maybe for 3, 4, 5 days. And of course, we have the damage due to the disease per se, but we have also many of these patients had a tremendous spontaneous breathing, which is the patient-induced, self-induced lung injury. These are the first signalation, 38, Barak, beautiful paper, Annals of Internal Medicine, Mascheroni and Kolobov, 88, and 2017, Brochard, Slask, and Pesetti on this paper on the Blue Journal. But it's always the same thing. I change the motor, I change the way I provide energy, but the big tidal volume obliged in this patient, which have a tremendous respiratory drive, and this one. And of course, nobody measured it. The people were looking. And who was measuring the tidal volume, the stress, the strain in spontaneous breathing patient? This is a friend of mine, died, first disease. Look here, the CT scan, 95 PO2 and 502. CT scan was almost near normal. This after 1 week of spontaneous breathing. Look here. Exactly as happens in the sheep of Kolobov and so on. Because we left this patient excessive spontaneous breathing. And I think the fraction of patients during COVID had this kind of problem. Now, I think Chuimello will speak about the importance in terms of prognosis or measuring the tidal volume, respiratory rate, mechanical power, in terms of prognosis, in terms of escalation therapy. So I will not stay on here. And just to complete everything, you have pressures we don't measure, but we can measure also spontaneous breathing. Volume, with experience we can measure. Respiratory rate, we can measure. PEEP. All this together represents the amount of energy. We need some energy because if we have zero energy, we die. But we need a normalization. And your experience has a good way to normalize what do I expect in terms of normal total ventilation. And I think to have a reference, if my ventilation is 2, 3, 4 times, may be dangerous in that particular range. Here we normalize the mechanical power, and the mechanical power is associated, of course, with that. But look here, this is a normalization. These are peaks in which we have the mechanical power ratio, which include, of course, ventilation, respiratory rate, and pressures. And you see that if we divide these peaks are under 20 peaks where the latter of different condition, but different mechanical power. We divide the mechanical power in 10 decile. And you see that when the mechanical power ratio was 3-4 times greater than normal, we have a ventilatory ratio, FRC, and respiratory impedance with AT, lung weight, light to wet ratio. This is fluid balance, this mean pulmonary artery pressure. You have a sort of threshold. That means total ventilation in terms expressed also as a possible threshold is not perfect, but is the way to look at and to organize mentally themselves, saying, okay, it's 3-4 times what I expect. I have a tremendous problem. And so at the end of the story, we have a patient coming, FiO2, CPAP, NIV. In all these 3 conditions, we do not measure almost anything. Then with mechanical ventilation and ECMO, we measure everything. But we have this tremendous lack that I'm grateful to experience, which may cover, at least in part, this problem. And my conclusion are that treating spontaneous breathing patient without monitoring is to drive in a foggy night without lights and without know where to go. Thank you for the attention.
Dear colleagues, good morning, good afternoon. In the next 20-25 minutes, I will revise the topics regarding the possibility to have a bedside respiratory monitoring. So, what's happened in patients admitted in intensive care with acute respiratory failure or with the most severe form with ARDS? So the patient is characterized, or the lung is characterized by pulmonary inflammation, by increase in lung edema. This can increase the lung weight, increase the alveolar shunt, is associated with the deterioration of gas exchange, hypoxemia, increase in dead space, alteration in respiratory mechanics, increase in respiratory drive due to inflammation, fever, hypoxemia, and this translates in very high inspiratory effort. So this very high inspiratory effort can furthermore deteriorate the pulmonary inflammation, the capillary link, so increase the lung edema. So the aim of non-invasive ventilation or any kind of invasive support is to reduce as much as possible the patient's self-inflicted lung injury. And how is possible, and how is the instrument and the data that we can use at bedside? Here are some examples. We can detect the impairment of oxygenation by use pulse oximetry. Then we have to record the respiratory rate by simple clinical examination. Then we have some problem, as Professor Gattinoni tell us before, regarding the measurement of tidal volume, because if you use helmet CPAP, we don't have any idea regarding how is the tidal volume. And also, we should also measure the inspiratory effort by putting an esophageal balloon catheter. How does it work, a pulse oximeter? Here is a clean example in the upper part of the normal signal. However, in patients with acute respiratory failure, ARDS, hemodynamic failure, sometimes have some problem to get reliable data due to low perfusion, the presence of noise artifact, and the presence of artery to the motion. In addition, if we get a good and reliable signal, how is the bias of the pulmonary pulse oximetry compared to the gold standard of the arterial saturation with blood gas analysis. And as you can see, this is a huge number of patients with acute respiratory failure ventilated at different FiO2. And as you can see, there is not very good relationship between the change in arterial saturation obtained by pulse oximeter and the change obtained by blood gas analysis. And the pulse oximeter always overestimate the gold standard. In this case is the blood gas analysis. Another important point is the respiratory rate. We usually, in patient with or without respiratory failure, after, for example, general surgical, when we put the patient in general ward, we record the respiratory rate. But in this study, it was simultaneous recording the respiratory rate and the tidal volume, left part of the figure, and the respiratory rate relate to minute ventilation. Unfortunately, the author did not find any significant relationship between the two. And if we can just see, this was an example of a patient after general surgery in which for 24 hours respiratory rate and tidal volume was recorded. Respiratory rate significantly increased from the end of the surgery and after 24 hours without any change in tidal volume. So unfortunately, if we want to have an idea regarding the minimum ventilation, we have to combine the two, so respiratory rate and minute ventilation. And why it is important to have an idea regarding minimum ventilation? This was a study in which patients with acute respiratory failure were ventilated with non-invasive ventilatory support, so pressure support with a mask, and patients who were present a good outcome, so who were not intubated compared patients who were intubated, present a significantly lower minimum ventilation and a significantly lower tidal volume. Similar data were recently found by another group, similar patients with severe respiratory failure and patients who receive invasive mechanical ventilation, so who get worse, presented a significant high tidal volume, and the odor ratio to receive invasive mechanical ventilation in patients who present very high tidal volume was very high, was around 80. So by putting together, we have to deal with the patient who present a respiratory failure, a increasing respiratory drive, present a lung inhomogeneity to the lung disease. This translates to increasing inspiratory effort, increasing transpulmonary pressure, and increase in tidal volume and respiratory rate. So if we can avoid and reduce volotrauma, we have to monitor and also to reduce as much as possible the developing of high transpulmonary pressure and tidal volume and respiratory rate. What we have now at bedside here is the respiratory ventilator monitor, and with this monitor it's possible to evaluate in non-invasive way the respiratory rate and the tidal volume and the minute ventilation. This device does not tell you exactly how is the tidal volume because it's not calibrated with the spirometer. Tell you just how is the change in the volume. In this study, a group of patients sedated and paralyzed underwent general anesthesia, and the tidal volume was simultaneously measured by the device and by the ventilator. And as you can see, it was found a very good relationship between the two during the start of the surgery, during the surgery, and also at the end. When the patient recover, so start to have an active breathing, the red is the spirometer of the ventilator, while the blue is the respiratory volume monitor. And as you can see in the blue, there are higher inspiratory effort not detected by the ventilator. And how is the accuracy? This in the bar, each bar represents a patient, and each bar represents the bias. So the difference between the respiratory ventilatory monitoring and the spirometry regarding the minute ventilation, the tidal volume, and the respiratory rate during the surgery. As you can see, the error of tidal volume and respiratory rate and consequent minute ventilation was quite low. Putting together all the data, so each point is a patient in different condition. This was the relationship between the tidal volume in the middle, minute ventilation in the left, and in the right, the respiratory rate. And as you can see, it was found a very good relationship between the measurement between the two devices. And try to better understand, the author analyzed the data by the blood-Altman test. The blood-Altman consider individual measurement of each patient in the different condition. In the upper part is the comparison between the two devices for the minute ventilation, in the middle for the tidal volume, and the lower part for the respiratory rate. In the left part is the difference, so the bias between the two systems, while in the lower part is the average of the measurement. And as you can see, the error between the two devices was quite low. This was another study in which it was compared spontaneous breathing, so in different setting, compared to the respiratory ventilator monitor. So during slow breathing, so very low respiratory rate, 4 breaths per minute, normal breathing around 10 breaths per minute, fast breathing, and also a chaotic breathing. And as you can see, there it was found a very good relationship between the two. Consider the patient by putting in the blood alt analysis the error, so between the two was quite low, was lower than 10%. So the machine works quite well. And what it is important also, the respiratory ventilator monitoring is also to detect the inspiratory effort not detected by spirometry. So the red line is the spirometry, in the blue is the device. This, as you can see in the right part, it was asked to the patient to perform an inspiratory effort by the mouth closed. And what's happened? The spirometry did not detect any change in the volume, by the device detect the change in the volume of the thorax. I would like to present just two recent studies that we published in patients with acute respiratory failure admitted in intensive care with COVID-19. This was lung CT scan image of 3 typical patients admitted with a respiratory failure that were treated with helmet CPAP. And as you can see, there is a different degree and amount of edema and impairment of gas exchange. So these patients were studied in supine position and then were put in prone position. The prone position was used not only to improve the oxygenation, but with the idea to reduce the inspiratory effort and the work of breathing, so to reduce the patient's self-inflicted lung injury. So when patients were moved from supine to prone position, the respiratory rate significantly decreased and the minute ventilation significantly decreased. This was associated to an improvement in oxygenation and reduction in PCO2. What's about the work of breathing? So the inspiratory effort. So this patient, the inspiratory effort was measured by an esophageal balloon, and we measure the pressure time product and the work of breathing. The prone position significantly reduced the work of breathing and the dyspnea scale of the patient. Here is the change for the work of breathing from supine to prone position in each patient. And what it was more important, this was the relationship in the right part of the change in the work of breathing by moving from supine to prone according to the work of breathing in supine position. So patients who present a high work of breathing in supine position were the patient in which the work of breathing were significantly reduced in prone position. The last study is a study in which we collect data in a lot of huge number of patients with COVID-19 respiratory failure admitted in intensive care that were managed with helmet CPAP. And the patients were followed from admission during the intensive care stay and were divided according to the final outcome. The final outcome was patients who receive invasive mechanical ventilation in red, and in blue, patient who did not receive mechanical ventilation. So, and as you can see, at admission, patient who did not receive intubation mechanical ventilation present a high oxygenation and a significantly different tidal volume. And here are the numbers. So patient in which continuous non-invasive ventilation compared to patient who stopped invasive mechanical ventilation and were intubated. And as you can see, the respiratory rate was significantly lower in patients who were managed with helmet CPAP, so with non-invasive ventilation, and the minimum ventilation was significantly lower, and the gas exchange was significantly higher. So how are the conclusion of my talk? Now, dear colleagues, we have the possibility to have a respiratory volume monitoring. This system presents a good accuracy and precision, both in intubated and not intubated patient. And we could have at bedside in real time relevant clinical information to optimize the respiratory support during spontaneous breathing and not invasive ventilation. Thank you very much.
Thank you very much, Professor Gattinoni, and thank you very much, Professor Chuimello. To the audience, we are opening questions, and you can post them in the chat, and then Professor Gattinoni and Professor Chuimello will answer them.
Okay, I see. Kari Van Gogh, are studies available for us? Well, I think what exactly you mean? We can provide a bibliography of the general bibliography on the volume importance and the bibliography of the study relative to experience. I think it shouldn't be any problem to get this one. And I receive a comment. Thank you, Professor. Very informative. Okay, thank you. I'm waiting for other question if you have it. Because I have a question for you. What do you monitor in a spontaneous breathing patients? In a patient with high flow or in a patient with non-invasive ventilation? What do you monitor? What's about to measure the level on the PMOSC? Okay. Diego Ernesto asked, what's about to measure driving pressure and the PMOSC? Okay, in spontaneous breathing, you need the esophageal pressure. And we measure routinely in this patient esophageal pressure. But I know a lot of people say, well, we do not measure esophageal pressure because it's another work. Many do not know how to use it. But if you have the esophageal pressure together with experience, that means together with the mechanical ventilation, the tidal volume, and respiratory rate, you may compute the summary variables, the mechanical power ratio. So you have a complete monitoring of the state of your patients. So I strongly suggest to measure esophageal pressure. If this would have been done in a COVID at the beginning, maybe some of the mistakes probably we did could have been avoided. So, Davide, can you see also how to
That's
measure?
for patient on nasal cannula.
Yeah. Can you answer to that?
Yeah, in the same way as Professor Gattinoni told us. So we can put an esophageal balloon, or we can have some idea by putting a probe into the nose during nasal cannula, so on the other part of the nose, and you can have a change in the higher pressure. This seems related, there is just one or two works, seems is related to the inspiratory effort, but it's not the same, it's related. So you don't have an exact idea how is the inspiratory effort. But for example, you can have also the change in the central venous pressure to have an idea regarding inspiratory effort. And also to look the patient, for example, to see the muscle. But the problem is difficult to have an exactly number, because sometimes there is no relationship, especially in patients with COVID, with the respiratory rate and inspiratory effort. As Professor Gattinoni told us, we sometimes have big result because patient seems quite well, so low respiratory rate, seems not too big tidal volume. Then we insert the esophageal balloon, and we found a very high inspiratory effort. So
You know,
sometimes
when you find a 10, 12, 15, 20, remind that normally, when you breathe normally, our swings of esophageal pressure are 2-3 centimeters of water. If we have 10, it's 5 times normal. If we have 20, it's almost more than 10 times normal. And it's a tremendous amount of energy which is required. So all stress, strain, and so on. And if you look at the patient, just looking, you don't see it. You are looking if there is any other.
yes, there is. Okay, what is the point to know the inspiratory effort? We already spoke. Is calibration for aspirin required for monitoring? No, there is no need of calibration.
Let's see.
Have you seen interference? No, this not interference. No.
What is the point to know the inspiratory effort? I mean, you ask her, what is the point to know the inspiratory effort of spontaneous breathing? For what we are saying, because all the damage you can have during spontaneous breathing are due to the abnormal inspiratory effort. And very high inspiratory effort means very high negative pressure. Very high negative pressure with excessive stress strain means excessive venous return in the central venous, in the intrathoracic. So all the bad things you can have are due to the inspiratory effort. If you take the horses, the running horses, they have blood after a big run. Exactly the same mechanism. Physiology behind is always the same. Of course, if you don't measure anything, you don't see anything, you will go sleep very quietly. But this is not for the good of the patient.
There is another question.
I see, because
Do you evaluate the diaphragm and intercostal muscle work by ultrasound? So, Professor, what is your idea regarding ultrasound? I think you like very much.
well, no, my God, I'm just old generation. I really, no, I prefer Chuimello answer this one. Personally, I don't use too much because, to me, when I read that after 3 hours, 4 hours, the diaphragm start to have problems, is a little bit in contrast with all my experience, because I had some patient maybe after extracorporeal support of 2 weeks, 3 weeks, they start to breathe normally uh, without tremendous problem. So I'm afraid that many things are written more to publish a paper than to have a really an important clinical impact.
Okay. How is possible to decrease the inspiratory effort in patients with severe metabolic acidosis?
Well, in severe metabolic acidosis, before to decrease the inspiratory effort, I will try to understand the cause of the acidosis, because the increased respiratory effort is the way the Mother Nature provides us to have a decent, a viable pH. You start to decrease the PCO2, you change your buffer base domain, you decrease the PCO2, increase the pH, and you try to compensate the metabolic acidosis. If you stop this, the risk you have tremendous increase of acidosis. And this also, when you are in mechanical ventilation, nobody changed the mechanical ventilation due to acidosis, but we cancel one of the main mechanisms, immediate mechanism that we have to compensate for that.
Because you are a great expert in acid-base equilibrium, do you use bicarbonate during metabolic acidosis?
Well,
It's an old story. Old story.
well, not really. It's a long story. We don't have time to that. But when you give bicarbonate, what really you give is a sodium. So you increase the strong ion difference, and giving sodium bicarbonate works if everything goes to the center. You may breathe. You may have not intact, but working circulation and breathing. If not, it doesn't work at all. Okay. After cardiac arrest, you can give whatever bicarbonate you want, and the pH stays there. If I have a bottle and put bicarbonate and I don't change other condition, the pH does not change, because I add sodium and I add CO2. So it's a complicated, but just to make the story very simple, I don't use it. You have to understand why you have the acidosis. Sit down, connect the brain, and try to understand and measure. Do you evaluate the diaphragm?
No, the last, Leo Brouwer, the last.
Do you evaluate diaphragm interstitial mass about us? No, I don't, but there are people who does it. Maybe it's promising, but this is my personal ignorance in this part of the field.
There is the last is how will you optimize the ventilation during high flow in terms of circuit flow rate? I use the maximum, around 50, 60 liters per minute. So in order to reduce as much as possible the inspiratory effort, so to get in an intrinsic PEEP. So the only way to reduce the inspiratory effort by have high flow nasal cannula.
Okay, but once again, I think we may speak realistically about this kind of thing if we measure it. If we measure inspiratory effort without an esophageal balloon, without knowing how much is the tidal volume. Tidal volume is the outcome. The inspiratory effort, you have to look at the motor. And the motor is how much negative pressure you produce in spontaneous breathing. Remember the slides in which I put the contraction of the muscles, PMAS, and so on. I think it's important to understand what we are talking about. Where, in which field, in which part of the field are we? So once again, measure.
Okay. Now I don't see no more question, Professor.
I don't see any other question.
It's 5 o'clock.
It's 5 o'clock.
Perfect time.
Is Zeit for tea, if you are in UK. If you are not, well, okay. I think good afternoon to everybody. Thank you for attending to this session. It was nice for us. I hope not very bothering for you. And stay well. Ciao.
Thank you very much. Bye-bye.
Thank you so much.